He'll be presenting by virtual talk. His talk is on management of submacular bleed in MNV. Welcome,
Dr.
sir.
Vinod, one moment, you are muted.
Yeah.
Can you
Sir.
unmute?
Yes, sir. Dr. Vinod, sir, please unmute yourself.
Am I audible now?
You are
Yes,
audible,
you are
doctor.
audible.
Please go ahead.
And is the screen visible?
Yes, visible, sir.
Okay. Uh, uh, at the outset, I'd like to apologize because I could not make it physically there due to some personal reasons, but definitely next time I would love to be there with you people. I'll be talking in short about the management of submacular bleed in macular neovascularization. So we know that most of these patients, they do present with sudden alarming visual loss. And I think we don't even need to see them. And we know that probably the patient has developed a submacular bleed. Now, it is seen up to in 10 to 12% of neovascular AMD. And we know from our experience that the submacular bleed is commoner in PCV. And now a little difference here, one should be careful that while subretinal bleed tends to be more harmful, a deeper subretinal bleed, which appears more darker in color, is relatively harmless because it does not affect the functioning of the retina. The subretinal bleed, on the other hand, is little more harmful as it precludes the nutrition reaching the photoreceptors from the outer choriocapillaries. When the clot in the subretinal space contracts, it leads to the shearing forces on the photoreceptors, and that can lead to further damage of outer retina. And the blood products which are there for long have iron, and these can produce toxic products which can harm the photoreceptor as well as the outer retina, thereby leading to permanent loss of vision. So that is the reason why most of these patients should be treated early before the all these harmful effects of the subretinal blood transfer onto the outer retina. Now, typically when we see subretinal blood, we need to ascertain what is the size of the subretinal blood. Usually they are classified from small to massive, while a small hemorrhage constitutes around 1 to 4 disc diameters in size. A massive one is the one which is extending outside the major vascular arcades. And anything in between them is termed as subretinal bleed of moderate size. Now, apart from size, what also matters is the thickness of the blood. And as per literature, if the blood thickness of the subretinal blood is more than 400 to 500 microns, that usually indicates a poorer prognosis and leads to and is more difficult to treat. Now, when it comes to management, when the patient comes to you, apart from our routine examination of anterior segment, specifically the lens and intraocular pressure, we need to document the patient's condition in terms of color photograph. That helps us to explain to the patient as to what has happened and why the patient has lost his vision suddenly. OCT is very, very important. It tells us about the level, thickness, and extent of the blood. It, in certain scenarios, would also tell us about what is the cause of blood, as in either it is a polyporoidal choroidal vasculopathy or it is a macular neovascularization. And also, if the blood is not too thin with recent advances in OCT with EDI and a higher wavelength OCTs, you can even ascertain if there is an underlying RP rip. And if that there is one which is involving the foveal area, then it helps us in prognosticating to the patient as to what is the likely outcome of the eye. Now, dye angiography, as Dr. Manyath mentioned, is not always useful, especially if you have a thick blood underlying the retina. This blood may preclude, even on ICG, the view of the underlying structures. And therefore, many a times we do dye angiography, especially once the blood has been displaced. And octa, especially again, the swept source octa may be useful in ascertaining the underlying pathology. But as we know, the polyps are not particularly well picked up on octa. Now, here are two scenarios. If you see, the first scenario is a large subretinal bleed, massive one, but there is a scarring inside the macular area. Now, here is a patient, you already have a scar in the macular area. And if you have a bleed like this is a patient who probably is not going to benefit much from the treatment. On the other hand, this is a patient where fovea looks relatively clean. There is minimal amount of blood beneath the central macula, and the blood is surrounding whole of the macula. Now, this is the patient again. Probably you don't need to do anything from the perspective of submacular bleed, but you need to treat only the underlying cause, that is the neovascular process. And third scenario would be here when the patient presents late, where there is old subretinal bleed in the inferior part, and you see that macula is already scarred up. Now, this is the patient who again actually does not need any treatment. Now, the patients who actually need treatment, there are several components of the treatment, and one needs to decide as to which all components are required in a particular patient. So coming to first and foremost, we need to displace the blood from the foveal area. Now, that is the most important thing in a patient with submacular bleed. And usually we resort to intravitreal gas injection and then followed by prone position. Now, depending on the availability and choice of the surgeon, one may use a short-acting or a long-acting gas, and this can be done with or without vitrectomy. You can inject the gas without doing a vitrectomy, or you can do a vitrectomy and then fill whole of the vitreous cavity with gas. Now, what it gives us is incomplete versus complete gas fill of the vitreous cavity. How it is important? Because many of the MNV patients are old age. At times, they will not be able to maintain a very strict prone position. So a simple gas injection without vitrectomy may not give us a large enough bubble, which would displace the blood without positioning. So therefore, especially in elderly patients who are not able to maintain a good prone position, I have a low threshold of doing vitrectomy and then fill whole of the vitreous cavity with gas. That gives a better tamponade to the macular area. Though there are some concerns about this half-life of subsequent anti-VEGF injections, which will be required in these patients for little longer time. The second part is anti-VEGF, which is again a mandatory part, because we know that most of we are talking about MNV here. So whenever you have a macular neovascularization related subretinal bleed, it's important that we treat these patients with anti-VEGF to prevent the rebleed and treat the underlying cause. Now, this can be as per affordability. Of course, the longer acting anti-VEGFs are better, but even the basic ones like bevacizumab do well, and they are better than doing nothing. Coming to TPA, now that is a question which is always confusing us: when to use it, how much to use it, and where to use it. For me, the primary indication is when you suspect that the bleed is clotted, when the blood is clotted, and that usually will depend on the duration of the bleed. So definitely, if the blood is more than 2 weeks old, and in certain scenarios when the blood is more than 1 week, one would like to inject TPA. The idea of injecting TPA is to liquefy the blood so that the gas can work well and displace it. Now, there are concerns whether one should inject it in the intravitreal compartment or in the subretinal compartment, but there are not many studies. At least one or two existing trials have shown that both work equally well, though biologically intravitreal TPA is known to penetrate less well as compared to a subretinal TPA. Now, though it lyses the clot, there are some concerns of increasing the rebleed from these CMEs once you use TPA in these patients. Now, all these three components are required depending on the stage and depending on the presentation of the patient. But what is important is that some surgeons like to inject this particular cocktail into the subretinal space. What it does is it creates a large cavity where blood can be displaced. This is done usually by a 38 to 41 gauge needle. And what it leads to, in my experience, I don't use this particular technique, but I've seen people doing, even in our institute, it does lead to faster displacement of the blood, but it is also associated with higher rates of complications in terms of retinal detachment and macular hole formation. So coming to a few cases, so this is a patient who presented to us with decrease of vision in his right eye. You can see there is an old blood here and a fresh subfoveal bleed. So this patient underwent vitrectomy along with TPA injection in the intravitreal compartment, Avastin, and a full fill of SF6 in the vitreous cavity. So this is 1 month later. So you can see the blood is still there. Some blood is there, which is clotted, but foveal contour is returning to normal. Most of the blood has become old and hyper AF now. This patient was continued on intravitreal Avastin injections, and you can see the blood slowly resolves, leaving behind good vision and good foveal contour. And in fact, this is 3 years down the line now, and patient has not required injections. And I think most of you would agree that if these patients bleed one, it is very rare for them to bleed again. So this is another patient who had a massive hemorrhage, you can see here, which is extending outside the arcades, a very thick, you can say, subretinal bleed and a large PED here. And this patient again underwent intravitreal SF6, PPV, and gas injection along with anti-VEGF, and over a period this patient also did well. Now, this is a patient, in fact, this is one of the most difficult patients of subretinal bleed I have encountered. So I wanted to share this case with you. Elderly lady who presented to us back in 2016. She had poor vision in her right eye because of a CNVM scar, and the left eye she had this extrafoveal CNVM here. So we discussed the option, but because patient did not want any scar and she wanted to have a good vision in her left eye, though there was no fluid in the subfoveal area, there was some fluid in the supratemporal area. She underwent injection of Avastin, and she was kind of not very active disease. From 2016 to 2021, she underwent Avastin periodically. She had around, you can say, around 14 injections during this period, but her frequency increase of requirement of injection increased in 21. And at that time she was in her hometown and she was given Paginex by the surgeon there. Now she underwent 3 injections of Paginex over this period, and the last injection was in March 23, and this was in April 23 when she presented to us with decrease of vision to 5/60. This was what was her presentation at that time. You can see the right eye had always been scarred up. Left eye, she had a massive subretinal bleed, which was involving the temporal macula and the inferior retina. You can see the subretinal bleed in the macular area was minimal, but more so in the outer areas. So at this point of time, she underwent injection ranibizumab with intravitreal injection of C3F8, and she was advised prone position. But she had a breakthrough vitreous hemorrhage, and because she was one-eyed, she wanted quicker rehabilitation. We took her for vitrectomy along with a repeat ranibizumab, and this time we filled the vitreous cavity with SF6. And 2 weeks later, she again presented, and the vitreous hemorrhage was persisting, and we again did a vitreous lavage for her. Now, this is in July sometime, and you can see she had come back to us. The vision had improved to 6/12. The fovea looked relatively good. She had a large RP rip in the temporal retina, and most of the blood in the other parts had resolved, but some places there were old altered blood. So at this time, because there was no fluid, we washed her. This is in August, and then subsequently in November, she was doing well, and apparently there were no signs of activity. In April 24, she developed subretinal fluid again, and we gave her another injection of Paginex. But in May, she again presented with a massive subretinal bleed, this time involving the macula. So again, we discussed with her and the relatives. She underwent a repeat fluid air exchange, SF6 gas tamponade, and a repeat ranibizumab. And to our relief, the patient again presented with resolution of bleed in 2024 in June, and the vision had improved, and which kept on improving, and the patient is stable till now. So
Dr.
at
Vinod,
times these
sorry to
patients
interrupt.
can be very
Can
hard to.
we summarize? Dr.
Yes,
Vinod,
sir.
sorry
Yes,
to interrupt.
last
Can you
slide. No worries, sir. Last slide. So at times it may be difficult to handle, but if you tackle these cases, but if you persist, you can maintain a good vision in these patients. So to conclude, we need a tailored approach to each case of subretinal bleed in these cases. Timely management can rescue the vision, and those spontaneous resolution can happen in small and thin hemorrhages. But in spite of all this and underlying age-related pathology, prognosis in most of them remains guarded. Thank you.
Thank you, sir. So, due to lack of time, I'll request Lekha ma'am, Dr. Lekha T, to come for her next talk on inflammatory CNVM diagnostic biomarkers and management principles. To you, Dr. Lekha.
Thank you, Dr. Anupam. So I'll be talking on inflammatory choroidal neovascularization, which is an uncommon yet an important sight-threatening complication of ocular inflammation, and it is the third most common cause after AMD and myopia. But in pediatric population, it is one of the most common cause of CNV. It is